This pandemic is first and foremost a public health crisis. The word pandemic comes from Greek, and it roughly translates to, of all the people. The widespread transmission of COVID-19 is a pandemic precisely because of the virus's ability to infect large swaths of people, and that has had a huge impact on the healthcare industry. Today in the Municipal Voice, we are bringing on Kate Lavoie, the principal and Connecticut public sector practice leader for One Digital, to talk about healthcare and municipalities. We'd like to thank our new premier sponsors at Digital Back Office Palo Alto Networks. Check them out at digitalbackoffice.com or paloaltonetworks.com. We'd also like to thank our sponsors at Gateway and Houstonic Community Colleges. The Municipal Voice is the Connecticut Conference of Municipalities podcast in collaboration with WNHH LP 103.5 FM. I'm your host, Matt Ford. As always, be sure to give us a like and let us know what you're thinking in the comments. CCM's Municipal Voice podcast continues to present a key forum on important state-local issues. The views expressed do not necessarily reflect the consensus views of CCM or our member municipal leaders. Kate, thanks for being here.
Thank you for having me.
So can you tell our listeners a little bit about One Digital and your role there? What is your mission and how do you accomplish that?
Absolutely, thank you. So One Digital, we are a national employee benefits firm out of Atlanta, Georgia, founded in 2000, certainly with the goal to leverage technology to create a better experience for both employers and employees alike in their benefits experience. So we do that through a sophisticated combination of consulting and analytics and human capital management tools in there, as well as certainly providing a comprehensive insurance package. And for municipal clients, collective bargaining support as well. So
yeah. So
locally, we have
a large part of what you guys are doing?
Yeah, absolutely. They're a large part both nationally and what we do in our local market. So we service both public and private employers alike, but we have quite a large book of public employers in there, and that's the practice that I lead.
Yeah. So, I mean, it's pretty clear that this crisis is going to have kind of implications and repercussions throughout the world. Our member municipalities are feeling it every day. But people have to keep working, and I'm sure work One Digital is going on as well. What are you seeing there as the major effects to benefit policies related to COVID?
Yeah, absolutely. So quite a lot. I think it's, we can certainly consolidate it down into, first and foremost, financials, right? So it depends on the type of policies that municipalities have. So you have some groups that are fully insured and some groups that are self-funded in how they pay both their claims and their fees to the insurance carriers in there. So claim trends alike, though, regardless of your funding, we're certainly seeing some patterns in there. So there's a dip right now, as you can imagine, folks not being able to go to their primary care doctors, scheduled surgeries, dental appointments, et cetera. You're seeing a big dip with that. You're also seeing a bit of a different type of care, right? So much more folks that are seeking telemedicine appointments in there, or maybe changing the way that they pick up their prescriptions. So they might be going more through home delivery services than just going into the retail. We're also seeing a lot on the policies that the carriers are implementing and giving some choice to as well on allowing, testing versus treatment in there, in the end dates to all of that, and how the group sponsors will be able to elect or end the coverage for some of those pieces with regard to testing and treatment. Some carriers and some products we're starting to see where they have returned premiums, right? So you see commercials and whatnot on that on the car insurance side, but we also
the
do
car
see that
insurance.
on
They are doing
the
that with some
healthcare.
of the healthcare stuff. That's good.
Yeah, so I think we'll see much more of a delay on the actual medical side, but we are starting to already see communication come on the dental side. We have seen it a little bit on the medical side as well, and it mainly affects when you have return premiums. That's more in a fully insured environment. But yeah, we're seeing some of that as well. And then I would say for the transitions for groups that are transitioning between different vendors in there, a lot of those transitions happen, especially for municipalities, because we, start budgeting and we start the process, much more early on than a typical private sector would. We are seeing a lot more responsiveness from the carriers on transition of care items or continuity of care, and really that out-of-network coverage transition. So giving some, extended time frames and allowing folks, if they are in some type of transition, to be able to seek in-network providers if there is a disruption, or if they're in the middle of treatment, et cetera. On there, having some extended time frames. So those are really the mainly, financials, I can't, stress enough, that's the biggest piece. But we are seeing some policy and some transition of care items
and
as well.
what do you think is driving some of those changes? Is it coming from the companies? Are there anything coming from like the state government, any of the executive orders or anything that is affecting that or forcing any of these changes? Or is it just kind of a natural response from the companies?
So I think it's a combination of both. So I think you're seeing a response, certainly there's loss ratios, right? So for fully insured groups, they have to maintain, requirements for medical loss ratios. So, I think that that can play part of it in there. And making sure that they're meeting that, because if you have, lower claims and whatnot, you have to be cognizant of that.
Kind of existing,
but it's,
right? Those were existing rules?
I'm sorry, say that one more time?
Those were already existing
Yes, existing.
they had in place, so not new to COVID or anything.
Correct, not new to COVID. But I think there's also the responsiveness as well, especially as you'd see, like, for example, on the dental carriers, where if they're returning premium payments and all of that, they're certainly doing a combination of the two of those things.
So it's been all over the newspapers about the financial effects of COVID, especially in our concern, the effects it's had on municipalities. Recently, the Office of Policy and Management with the state released a survey of partially reported expenses, and they're estimating that towns and cities in Connecticut have spent over $62 million on this already. Is there a way to model out the financial effects of COVID and what it will have on municipalities in the coming budget seasons?
Yeah, that's a great question. So, certainly I think the level that municipalities are being cognizant, spans far beyond just the benefits arena and the unknowns to what can happen as far as the financials. But I think it's important to recognize that within the healthcare, there's absolutely a way to model out. And hopefully most of our municipalities have seen something in modeling, or will see something within the modeling quite soon. Because, we in particular at One Digital, through our national analytics team, we have a model that really looks at, and we've looked at this, of course, for all of our clients. So within municipalities, if you're looking at four general categories of risk, if you're looking at your age, if you're looking at industry, if you're looking at geography, gender, what we tend to see at municipalities is that they are medium or high risk for every one of those categories. Right? So that's important to notate when we look at differences. Anytime you look at difference between a public and a private employer, municipalities, almost all of them, again, you're seeing high risk categories on each of those. So what does that mean? In our particular model, how we look at it is, we see the risk model for those particular indicators. And then furthermore, we're looking at controlled versus widespread in there. And so I think, I'm going to oversimplify a bit, but what we're seeing, of what's coming out of our model is that typically within a group, we're seeing about a 3% infection rate. Not everybody is showing symptoms within that though, right?
Yeah.
So further than that, we're only showing about 2%, again, what's modeled out that are actually showing symptoms. And then about 1%, again, oversimplifying, but requiring hospitalization. So if you look at the general numbers, and in our actuarial model, it's built from many, many, many different data sources in there. But the average claim, if you're looking at that, being from for those who are hospitalized between $20,000 and $70,000, of course, that's going to be vastly different if you're in certain parts of the state in there. But using, again, oversimplified, but those general, we're seeing anywhere from 1 to 3.5% impact to a program's budget. So there's absolutely a way to model that out, and it's very important for the different components and what you're looking at from a budget from a municipality that you have an understanding of some of that.
You mentioned that when you look at municipalities, they tend to have even higher risk groups, a higher percentage of some of the risk groups. Is that based on is the population a little older in general, or is it because you have first response, like police and that sort of included in those in-town governments, and they're obviously putting themselves more at risk? Is that sort of what's playing into it?
Yep. So those are two great examples. Yes. Yeah. So the age certainly
it does
plays
a little bit
in there.
The private sector.
Correct. Yes. Okay. So it is, and that's exactly it. So for industry category, you certainly have to look at the first responders being as part of that. For age category, you have older workforce in municipalities. In there as well. And then, of course, when you look at the gender composition, all of this pulls back, not to get too technical, but all of this pulls back to pneumonia rates and all of that within various different age groups and gender categories and industry, et cetera. So
that's kind of what you're basing it off of now, is the pneumonia rates, because we don't have as much information on the COVID yet to really have good models. Is that kind of where you're at?
So interesting. So the first, I would say, when the models were first built, they were based on pneumonia rates. Now that we have much more data, there is actual data that goes in there from the COVID in there. So that was sort of the first phase of the model. And then you move into the phase of the model where you're able to take more data related to
so it's not
specific to COVID and
being updated as you're going along.
Oh, yeah. Okay. Yes, absolutely. Our model is actually updated nightly, every single night. So that's, from the latest data. So first, yes, you started out in that place where you had to take general statistics, right? From pneumonia rates. Then you have, you've got ICD codes now related to this, and you have the ability to look at it sort of in that second phase in there. And I will say that the third phase of what we're looking at sort of comes to the hidden part to this. And that third phase is really going to be what's happening within the groups for folks who are not seeking care, right? So you have folks who are missing their annual preventive exams, those, mammograms, colonoscopies, general exams, and all of those missed appointments lead to a negative effect on your population health.
Okay, so you're not just talking about people showing up with COVID, it's people not showing up for their regular stuff that they would have otherwise. It's also affecting.
Absolutely.
Okay.
Yeah. So the model itself, it doesn't just take in COVID, right? So it's taking in the data related to that. It's also taking in the data related to folks not going to their appointments. So the downward effect to claims as well right now, but then the COVID. And then I think, again, sort of the third phase of the next part of what we're releasing is really going to take in that population health and what's happening within our groups for those, again, those missed screenings, because we all know that, the more preventive care you have, you're going to catch diseases quicker. People are going to have more compliance to things like diabetes and, top 5, certainly chronic conditions
Yeah.
And we don't want to see the rates of that certainly in compliance to that plummet, because it's going
Yeah.
to affect the overall cost and claims to groups.
Yeah, that's something I didn't necessarily think of before. It's not the disease itself; it's people not taking care of their other problems because they're worried about that. And that also reminds
Absolutely.
me. You said earlier, talking about costs and models and stuff, talking about ongoing unknown costs
Mm-hmm.
and things, such as how long will we need masks? It could
Mm-hmm.
be a couple months, it could be a couple years. How do
Mm-hmm.
you model how much something like personal protective equipment, how much it's going to cost to buy that? And are there other kind of hidden costs that you've come across in this crisis so far that, the general populace might not have thought of?
Yeah, so that's another great question. I would say, every municipality is certainly different in
Mm-hmm.
how that they're modeling some of these costs, especially, with the amount of public that might come into their town halls, or if
Mm-hmm.
they have different centers where people are coming in to pay different types of tax payments,
Mm-hmm.
et cetera. Different, it certainly spans, of course, to the different policies and procedures
Mm-hmm.
that municipalities are putting in place, both to protect their employees and the
Mm-hmm.
public in there. So I think, it's hard to make a generalization,
Mm-hmm.
certainly, because you have all these different types of environments.
Yeah.
But, when they're looking at the personal protective equipment and, there's a lot of guidelines, certainly from the CDC on, wearing masks or temperature checks, for example. If you're doing temperature checks,
Mm-hmm.
how many screening tools do you need? What type of screening tools are you going to buy because of how quickly you need to get
Mm-hmm.
folks in the building? How many people are you trying to go through, et cetera? So there's a lot of planning, I know, that's going
Yeah.
on from a lot of the conversations I've had around the state, certainly, both on, cities and, towns, boards of
Mm-hmm.
education, et cetera. How do they, what type of equipment do they buy? What policies
Mm-hmm.
do they put in place in there? So I'd say one of the other hidden things that we're looking at also from the healthcare side is
Mm-hmm.
for groups that are self-insured, which means, they pay their claims as they come through. We're also looking at the pressure that COVID is putting on what's called their aggregate stop loss. So
Mm-hmm.
when I mentioned previously that, on an average claim, if you're seeing in those hospitalizations $20,000 to $70,000 for a
Yeah.
hospitalization, those pressures really aren't meeting what are called individual stop loss levels of programs. They're meeting those, and they're putting a lot of pressure on the aggregate. So I
Okay.
would say that's another item. So beyond looking at the population health, we are also looking at the aggregate stop loss pressure that's being put on, and are those levels set properly, within programs, and is there some undue pressure being put on that if it's not?
Yeah. You said, there's so many different situations going on in different towns, depending on size. When benefit providers are looking at this kind of stuff, are they taking into account if a municipality has a stricter sort of lockdown going on their public buildings, or their ability to isolate people? Is that part of the equations yet, or is that?
I would say not yet. In terms of what they're doing at the municipality, so there's a lot of conversations. I'm fortunate to be privy to a lot of, the conversations that go around the state through some of the different organizations that I belong through, where we hear a lot of these conversations voiced in a lot of the concerns voiced in there. So from a benefit policy standpoint, I think that certainly you can play that into the financials and the actuary and how you take a look at the prevalence rates in there. So there's always an art and a science to underwriting and to actuary. So certainly some of those can come into play, and the rates, right? So if you have a more controlled environment versus a widespread environment, if we know that a municipality potentially is maybe less strict maybe in our assumptions, we're going to go more towards the middle ground versus that very controlled actuarial value versus the widespread, right? So certainly that comes into play as the art
probably
portion
more
of
so
how
in the
we help
future
them with
as
the
sort of
financials.
information and standard procedures kind of become figured out, like what the recommendations are, so on. You are listening to the Municipal Voice on WNHH 103.5 FM, sponsored by Digital Back Office and Palo Alto Technologies. What are the municipalities you're working with? What are their top concerns regarding reopening right now?
Yeah, so another great question. You know, as I mentioned earlier, I'm fortunate to be part of a number of different groups and hear some of these top concerns in there. And, you know, I think one of the main things that I would say is there's a lot of confusion from some of the municipalities of reopening because having never really truly been closed in certain cases. So not all, you know, town halls, for example, have been closed. Now they may be closed to the public, but not to employees. So you still have, you've got shares of employees that are home and folks that are still going in. So what type of policies and procedures have to go in place? And, you know, are you correcting some things that need to be? So it really kind of comes down to four areas, which, you know, are the policies, it's the training in there, it's budgeting, and it's the logistics of everything sort of coming into play. So, you know, with policies, we started off on work from home policies where, you know, as a generalization, municipalities really did not have work from home policies. Folks did not work from home. So it was sort of a mass scramble to get a skeleton of work from home policy in place. And I think over time it's evolved to, you know, ultimately, how do we progress our work from home policies so that both us as an employer and employees are protected within those policies? Because there's a lot of flexibility, as we all know. You know, this is an environment where you have a lot of parents who are trying to you know, monitor schoolwork and do their jobs, you know, all at the same time. So, you know, whereas if somebody is just in office, you have different overtime policies that have to be looked at. There's just there's many different facets from the HR side that we're seeing on that. So with the reopening and how that plays into the policies, certainly is, you know, what are the procedures going to be? Is are you going to have folks, you know, sign an affidavit once before they come in that, you know, that they are not feeling ill and, you know, require them to wear a mask to their desk? And, you know, what's the policy procedure there? Or are you going to go as far as having, you know, temperature checks for every single employee and, you know, only allow, you know, again, per the CDC, per guidelines, you know, a certain number of folks going in and out of break rooms and what are your cleaning procedures and all of that. So I think, you know, that's, as you mentioned, it's the biggest elephant in the room right now is being that a lot of these municipalities haven't really closed. And there's not always clear guidance from the state, I think, as well, on how do they, you know, reopen.
You also mentioned some CDC guidance. Has that been one of the main sources for guidance on new policies for towns, or are there other good information sources that you've found for information on COVID policies?
Yeah, so I think you have to look both nationally and locally, certainly. So I think there's local guidelines, of course, of you know, state specific that have been released to cleaning procedures and all of that, and general reopening guidelines. Again, as I mentioned before, I think one of the tough things is, and then I'm seeing in some of the communication that will be sent, sort of interchanges between the groups, is there's a lot of folks who are looking for, you know, clear questions to be answered, you know, from the state level. And, you know, ultimately, what type of retraining programs do they have to do? How do they be cognizant of the fact that they have a lot of workforce who might be in a high risk, not only a high risk category in there, but they might have personal health concerns as well. And how does that play into them opening? How do they maintain the flexibility as well? So I think a lot of those different components come into play.
Beyond COVID, just, before all this started, what were you seeing as the trends happening in municipal benefits? And do you see some of those trends falling to the wayside now because of COVID?
So I think in municipalities, which are, they're certainly very distinct in the way that healthcare and the way that they communicate to their employees, the way that they utilize technology, et cetera, in there. So I would say, as a generalization, we're seeing from a trend basis, there's always been activity in the group purchasing or consortiums, captives, for all different facets of what municipalities do, certainly to try to, gain greater efficiency, right? So we are definitely seeing, from a trend basis, still a lot of activity in that, in really exploring new, group purchasing and consortiums, captives, all of that. I would say specifically this year, we're seeing a bit more movement between vendors in there, a little bit more than we've seen historically for carrier vendors. So that's, again, a lot of those decisions were made prior to, COVID coming. So there's a lot of trickle down effect of the differences that we have seen in the responses from that, but still a lot of movement for annual policies, which for municipalities is 7/1. So a lot more movement there. I would say, within the carrier and pharmacy benefit management, or PBM, so we've seen a lot of changes as, everybody sees on the news, CVS, you can see Aetna, Cigna, ESI, all these different, companies who might be coming together. And with that, I will say that we're seeing a lot more looking at potentially carving in also within some of these carriers. So where you could have seen traditional carving out of pharmacy benefit management, we're starting to see some movement back into the carrier. So that is new, certainly for this year. I would say within municipalities, we're seeing a bit more from what the carriers are releasing for closing gaps in care programs as well. So trying to close gaps in care for specific conditions in there. If an employee calls into their carrier hotline and the carrier notices that the representative that they're speaking with, it maybe they haven't been to their preventive exam, this year, and giving a soft reminder to the employee. So with that, anytime you close those gaps in care, again, your health of your group is going to improve overall. So that's certainly a trend that we're seeing within the carriers putting in place and in the municipalities adopting. I would say moving forward, where we didn't, the programs didn't always exist in the past, but we're seeing much more adoption rates to that as well. And then, just to add a little bit on COVID, because it goes back to how municipalities have historically sort of used healthcare. In general, we haven't seen, very high adoption rates to things like telemedicine. Now with COVID, as you can imagine, we're seeing higher increases, right? So to telemedicine, and I think, especially as we move through the summer, for folks who maybe have already had some of those visits, they may use telemedicine for things like the poison ivy, the things that you are really meant to use telemedicine for. So having that be as a trend of an uptick in there. And as I had mentioned also previously, with, pharmacy, more folks, potentially getting their prescriptions through these mail order services versus just walking into the retail side in there. So, and then I think some of the other trends go back to, communication with their employees as well. So how do municipalities communicate with their employees? Of course, historically, it's been a very manual process where they might have employee meetings, et cetera, which are very important. And we're seeing a lot of success and adoption rate through a Zoom, just like the technology that we're on today. So I've sat on many different meetings. Folks are on there really gaining their education to their benefits programs through Zoom. And then with regard to what you said for things that have kind of gone by the wayside, I would say some of the traditional items that have not had as much adoption in the past, where, wellness or well-being programs, I think certainly during this time, for the groups that have the plans, securely in place, I think, it's one thing. But certainly for groups that are trying to adopt that's sort of been on pause, I think, for a period of time. Technology in general, trying to get technology in to help enroll employees, through technology, that's sort of been, kind of put to a pause button on. Outsourcing. So there's outsourcing for certain things like FMLA or various different types of retiree billing, what have you. Certainly where we've seen more activity of the want to those things. But I think with COVID, those have been put on pause, of course, because there's budgetary concerns. There's, the fact that HR departments are spending so much more time on all of this in there. And then, I think, of course, they have to spend a lot of time on trying to figure out the legal and the compliance portions of all this as well.
You mentioned a little while ago the telehealth that people are doing right now. Obviously, right now, it's safer for everybody to try to do that when possible. But have you seen any research? Has there been any yet as far as is telemedicine useful as going in? Like, is it as effective?
Certainly. So I think there's a time and a place for telemedicine, right? So, it certainly doesn't replace an in-person visit where, there's again time and a place. So telemedicine traditionally is really has meant for some of the visits where you don't have to walk in or wait to go into your doctor's office for an appointment because you might have your child might have pink eye or you have poison ivy or you have the same sinus infection that you get every year or you have the allergies or et cetera. So that's where you've traditionally seen telemedicine, and that's where telemedicine, certainly works best. I would say that there's a lot of general appointments that are being moved into telemedicine right now for, general checkup appointments. I think there'll be some movement there, right? So if appointments, can constructively be put in that environment, I think there's going to be a lot more opportunity for that. But I think where, folks need to go in for your annual physicals where, doctors require their, touching different parts, to your body during an annual physical, or you have to go through the actual testing, et cetera. Nothing is going to replace certainly going through with that.
So maybe a quick call. Hey, I've got the sniffles. Can you give me the same allergy medicine you gave me last year? Might stay as telemedicine going into the future, but a lot of things will eventually probably go back to in-person visits.
Yes, that's what I think.
Sounds good to me. You also mentioned a little bit, talked about municipalities saving money with collective bargaining, group purchasing things. Can you give our listeners a little bit more insight into exactly how some of those savings would be realized, like what sort of things they can do through collective bargaining to save municipalities money?
Yeah, so I would say, so I'll answer this in, I guess, a little bit differently in that, so unlike a private employer who, if they are in a crisis mode, they can cut benefits, right? If that's sort of a last resort, where they may change their program, they may change their deductibles, their co-pays, they may change their formulary, they may change the way some of their financials are dealt with, et cetera. You can't, in a collective bargaining arrangement, you collectively bargain your benefits. So a municipality can't go out and just change the structure to that. So what can they do in there? And I think that it's so important moving forward that there's certain items that they certainly are looking at. And I would say the first thing is going out to RFP. So if a municipality has not been out to RFP, or if they don't have a constructive process to looking at their vendor relationships, carrier relationships, that's certainly the first thing. There has been a lot of change in the marketplace in the past couple of years. And that's now when municipalities go out, there's certainly a certain number of vendors who are, of course, licensed in the municipality market across the state, and they provide something called equal to or better, substantially equal. They're letters that guarantee that the collectively bargained benefits are going to remain the same under their platform in there, or equal to or better. They will improve those. So I think that being said, certainly going out to RFP, I think it's important that municipalities are looking at things like potentially as something as simple as a multi-line discount. So, if, and again, this is for a certain segment of the market that might be fully insured, where they're paying their, premiums times the amount of people that are enrolled there. But multi-line discounts can ultimately could save, a couple percent off of the rates there. And sometimes it ends up saving for certain lines of coverage. They could end up saving amounts of money that are over what they're paying for that line of coverage. So that's important to take a look at. I think that, for our larger groups who have pharmacy contracts, they might be self-insured who have pharmacy contracts. I can't stress enough how important it is to be looking at those pharmacy contracts really be, looking at the terms that are included in there. Are you getting to a lowest net cost on your pharmacy contracts, or are your pricing terms, your guarantees that are set in there, you want to make sure that it's driving towards that lowest net cost and not driving towards higher rebates. Because ultimately that's costing a municipality more. So I think those are some key, of course, looking at your funding strategy. As I've mentioned a couple times, fully insured versus self-funding, really looking at that funding strategy. Is it appropriate for where you are, for your risk tolerance, for your financial situation in there, looking at your stop loss levels. This is a critically important exercise to be doing, every year, is to be looking at, what's happening within your claims, and are those stop loss levels, whether it's your individual stop loss or your aggregate stop loss, are they appropriate? Do you have undue pressures coming on there from COVID on the aggregate side? So those are key. I would say some other items are audits. If you haven't done a dependent audit in a period of time, audits can have hundreds of percent ROI on the dependent side. Claim audits on both the medical and the pharmacy side, the dental side in there. I think those are, all very important. I think one of the other things that certainly to mention that we're seeing a little bit more activity on is the retiree strategy. In there. So have you looked at, Medicare Advantage potentially versus if you have some of the more traditional products in place? The state program moved over, SPP, the state program moved over to having Medicare Advantage. TRB, the Teachers Retirement Board, they now have Medicare Advantage. So really assessing, again, where you're not you're trying to look at within the environment that you have today, what are some of the factors that you can really look at to be saving money? And those are all huge factors. I'd say the other thing, just as I had mentioned on the trends, but making sure that every year you're really assessing the various different group purchasing and collective, not collective bargaining, but captive, consortium, et cetera. What's available out there? Do you know exactly what's available out there and what you have the opportunity to be taking a look at and assessing for your specific municipality?
So they just need to do their research, do their homework, and not just sign off on the same thing from before, just see where there's opportunities.
Absolutely, yeah. So it's critically important, especially given COVID and especially given a lot of the changes in the healthcare market in the past couple of years.
One of your coworkers, Ron Theriault, is a principal at One Digital. He wrote a blog on the Connecticut Partnership Plan from a few years ago. Can you tell us a bit about what the Connecticut Partnership Plan is?
The Connecticut Partnership Plan, also known as SPP 2.0 at this point. Basically, it was, there was legislation that allowed municipalities to go under the Connecticut benefit offering through the CBAC contract. And ultimately, right now, there's over 200,000 members within that program. There's about 23,000 employees under municipalities, about 56 or so thousand members, 125 groups that participate. And so what it is it's a very rich plan design, PPO plan on the medical side, a dental and vision program offering, and they have Anthem. Well, it'll be Anthem as of 10/1 for existing groups. In there, they had to have a delay because of COVID, but that is the medical vendor, and CVS is the pharmacy vendor. Cigna is the vendor for vision and dental in there. So a little bit more about the program. Basically, boards of education or towns are considered full groups and can go in without underwriting requirements. Housing authorities, water districts, we see a lot of different types of public groups that can go in there. You also can apply as if you're an individual union group.
And what about like,
but that
councils
is
of government? Would they be in that sort of arena too?
They could, and COGS or RESCs as well could certainly go into the state partnership program, as long as they're, public entity. And basically, you go in, it's a 3-year commitment going into the program. As I mentioned before, it's a very rich plan design. It's actually what's called the 3-tier structure. So they have an enhanced in-network design on one side, where if you go to the ultra preferred providers, in a lot of cases, you might have a $0 copay for those because of their how the structure is set up for that. And there's no, deductible on the plan unless you don't meet what are called your HEP guidelines in there. And that brings me to the next point, which is that they have the health enhancement program. So they have some ties into it. There are requirements that employees have to get certain exams done, per year or per schedule. It depends on your age group. And ultimately they have a full schedule out for that. More recently, they've done some differentials in the rating per county. So I think, as they saw some loss ratio issues in the past, that was one of the changes that they made, is that they were going to go and rate per county. Historically, what we have seen, I would say, for the municipalities that have joined, there's been a little bit of adverse selection, is what I would say. You saw a lot of Fairfield County type groups, which had much higher, premium costs in there. You also saw groups that just, did not have good claims experience, and they were getting higher rate increases. Or you may have seen certain segments of self-funded groups that were smaller on the self-funded side, that just, claims were continuing to kind of hit them each year, and it made more sense, to move on to the program in there. And So, yeah, I think, certainly there's tons of information that you could share. They have a website that somebody, any member can go on and take a look at in there. I think there's some important pieces that would have to be notated, should you move in. We take an agnostic position. We analyze it every year for our clients. In there, it's important to do that, but there's certainly a lot of analysis that has to go into it and make sure it's the right choice, because there are some requirements that you have to.
So not necessarily
to.
the right fit for everybody, but for some people there are good opportunities there, certainly.
Yes. Yes. So that's key there. It's not the right fit in there, and it's not the right fit for a lot of municipalities, but it is the right fit in certain circumstances in there. So I think it's, what we do see is, I will say, is that the what we call the actuarial value of the program, it's significantly higher than where you're seeing most municipalities at. The plan design is pretty different. So we've seen a lot of adoption rate into high deductible health plans, within a lot of municipalities, and this structure is a very rich copay program, which of course drives higher claim activity in there. So, I think there's a lot of moves certainly being made on the state part to drive centers of excellence and lower cost care and all of that. But it's important to notate the financial history and, the premium increases that they've seen every year on that program, and some of the systemic, adverse selection that's happened there, and ultimately, if it's the right choice or not for a municipality.
All right. So kind of final thoughts. Is there anything else that you think municipalities should know about, maybe information they should carry with them through into 2020 and into the future? What's your final pitch to the municipalities out there?
Yeah, absolutely. So I think, first and foremost, if you haven't seen anything on a return to work, toolkit, get your hands on one. That's going to be critically important. There's so many different facets of items that you have to look at for return to work toolkits. If you haven't seen any impact reports in there for ultimately how that's going to affect your plan, certainly want to be taking a look at that. Have some resiliency planning. You have a lot of very stressed employees who are trying to juggle a lot of hats right now. What type of resiliency and well-being and, financial wellness programs, what are you setting up in place ultimately to try to help those folks? Really want to make sure that your HR policies are tight. We've seen lots of, news and sources, saying ultimately, the lawsuits that could come out of this are really great. So really want to make sure that your HR policies are tight. I think another key thing is, of course, always spreading the message of how critically important it is to get preventive care to your employees, so that overall, the health of the employees is improving. One of the other things I would leave it with is just on the financial side, really making sure that there's an understanding in the projections and the future planning that's done, that they're done at the right time periods. There's not overestimations of some of these claim decreases that will underestimate future costs, right? So that's going to be really important moving forward. We actually have a model on our website through our COVID tool where, if you haven't seen some of those impact reports, we'd certainly encourage folks to take a look. And it's no cost. There's an analysis that can be provided back to that. But overall, just take take precaution and plan for some of what we've seen.
Great. Well, thanks so much for speaking with us today. It's been a real pleasure.
Thank you for having me.
Thanks to our premier sponsors, Digital Back Office and Palo Alto Networks, which you can check out at digitalbackoffice.com and paloaltonetworks.com. Also, thanks to our sponsors, Gateway Community College and Housatonic Community College. Learn more at gatewayct.edu and housatonic.edu. The Municipal Voice is a co-production by CCM and WNHH 103.5 FM. Kevin Maloney is our executive producer, Christopher Gilson is our producer, Harry Draws is on the boards, and I'm Matt Ford, your host. Be sure to check out our Facebook page and give us a like, and watch out for our CCM chat series on our YouTube page.